So today we're finishing up, well, we're starting actually and finishing Learning Plan 4, which is Managed Care for Patients Experiencing Personality Disorders. It is a rather short learning plan, so I should be able to finish this in one sitting and not have to delay. And then next week is basically week 5 of the semester, and you're not assigned any particular learning plan. It's just really a time to get caught up with the 4 learning plans and study. Send me an email if you have any questions about anything. Watch some of the videos and just kind of start preparing for the exam, which will be coming up. I have to look at the date actually, but anyways, the exam will be at the beginning of week 6, so it's not, the exam is not next week already. You do have an extra week to kind of study and assimilate the material, especially because Learning Plan 1 kind of went on forever. There was a lot of material covered. I will be sending out a kind of a little PowerPoint study guide one of these days soon. So chapter 24 in your Varkarolus is on personality disorders, so that's where your reading comes from. And we have 3 different clusters of personality disorders. So basically, these personality disorders are kind of in clusters because they have some similarities. For example, cluster A are considered more eccentric. So the behaviors are a little more odd or unusual, and actually they're kind of bordering on psychosis, so which is a break from reality. So that's kind of why those 3 are clustered together. And then B is erratic, so they're highly emotional, and sometimes their behavior is very difficult, unpredictable, things like that. And then cluster C are more of the anxious personality disorders. So that's why they're kind of clustered together like that. You do not need to memorize the fact that they are in clusters, or, you don't need to know what cluster A, B, and C are. And I will send out in that PowerPoint study guide, I will send out probably the personality disorders of all the types that are mentioned here. I will send out a study guide as to which ones to really focus on, because some are more common than others, and we'll see different personality disorders much more frequently in the hospital or other healthcare settings more than some other ones. So basically, you might be thinking, well, what is a personality? I mean, we all kind of know what personality is. Everyone has a different, unique personality, and we all have different personality traits. Some people are just very bubbly and outgoing. Some people are quieter and more introspective. And some people are more shy. Some people are more willing to take risks and dares. We all have different personality traits. But when we're thinking about a disorder, we really are thinking about a deeply ingrained pattern of interacting with other people and interacting with the world. And if you have a personality disorder, then obviously that means that there's some pathology associated with that. So they're not healthy. None of these are considered a healthy way to interact with other people or with the environment. Personality disorders can be extremely challenging to work with. Your book kind of does a nice job of this on page 452, right in the very beginning of the chapter, where they talk about the clinical picture, and they're saying they're really among the most challenging and complex disorders to treat. People usually they present very significant challenges to healthcare providers. They have problems with empathy and with developing relationships with other people, and they may really not believe that they have a problem. They may really believe that the problem is other people's fault or something outside of themselves that they can't control. So they're not necessarily aware of their behavior and the impact on other people, and they may not even think that it's their fault. So they will externalize and blame. That's actually another defense mechanism, is just kind of externalizing and putting blame on other people or other events and not taking responsibility for yourself. So that makes it extremely difficult and kind of frustrating sometimes for the healthcare worker to work with somebody that has a personality disorder. So about 6% of the global population has a personality disorder. It's about 50% of psychiatric patients. But honestly, that number might even be a little higher, because I know that there are some doctors that are very hesitant to diagnose somebody with a personality disorder, because honestly, if somebody comes to the emergency room and the staff see that they've got especially a borderline personality disorder diagnosis on their chart, right away everybody kind of gets their defenses up and they're stigmatizing that patient, and it's like, oh no, they kind of know what to expect. Yes, those patients are extremely difficult to work with. So I think sometimes it's so stigmatizing that doctors aren't necessarily willing to put that diagnosis on there, because they want their patient to be able to get fair treatment. Now, I know that seems kind of sad that we have to do that, but I really do think that I know that some doctors are just very hesitant to put that diagnosis out there. But honestly, if you're really a healthcare worker that is non-judgmental, and you just really are the type of person to take everything into consideration, and to me it helps to have that diagnosis, because then when they interact a certain way, then you can understand more where they're coming from, and then that should help you to interact with them professionally and therapeutically. So to me, hiding that diagnosis isn't necessarily helpful. I'm just throwing that in. So because I do see that happen. So anyways, overall emotional dysregulation is amplified in these personality disorders. And some risk factors, certainly there can be some genetic predisposition, and usually that might be if they have a genetic predisposition towards anxiety, depression, schizophrenia, substance abuse, any of those other anxiety disorders, any of those other types of disorders, it certainly can exacerbate the symptoms of that personality disorder. But really, in and of itself, a personality disorder is not, as far as anything I've read, is not necessarily like 100% genetically, manufactured. But it's just that if people have a predisposition to some of those other illnesses, that can make the personality disorder really exacerbated. So they might have some neurological predisposition, some neurotransmitter changes in their brain possibly. But honestly, psychological and environmental are huge. And I just read an article today really speaking to the fact that, especially for like the borderline personality disorder, but many of the other ones too, usually trauma is associated with a personality disorder, and many times it is like severe, unrelenting child abuse. Basically, they have been the product of parents perhaps that just have not, parents, grandparents, whoever raised them, just in a very dysfunctional manner. So it's very, very prevalent to see that in somebody with especially borderline personality disorder. So they have been abused, neglected, did not come from a very supportive, nurturing type of environment. So being subject to all that kind of stress definitely can shape the way that their personality is developed, and then the way that they interact with other people and the rest of the world. So the diathesis stress model, again, pretty much for most of the disorders we're talking about, has to do with the genetic predisposition, neurotransmitter, neural regulation system, and stress. So you add stress on top of having that predisposition, and that is usually what is considered to be the causative factor. So cluster A, paranoid, schizoid, and schizotypal. So if you think about those three words, two of them actually start with schiz, or SCHIZ, which kind of sounds like schizophrenia. So actually, yes, there are some similarities. And paranoid, when we think about people that are paranoid, we might think about people that are psychotic, and they actually have delusions, which are false beliefs that are not based in reality. And so these three in cluster A are definitely, you're getting close to the psychotic disorders. You're kind of getting close to schizophrenia. But it still isn't quite the same. So we'll kind of go over what the differences are. And I know Learning Plan 5 is on schizophrenia and psychotic disorders, and I know we haven't come to that yet. That'll be for the next exam. But anyways, as some of these conditions, these personality disorders in cluster A can actually be almost like a precursor to schizophrenia. So paranoid personality disorder, about 2 to 4% of the population might have this. It might be apparent in childhood already, so some children might already have some aspects of just being a little more suspicious and not trusting, things like that. They may have had some social anxiety in childhood, so not necessarily like enjoying close relationships with people. So again, that could come from what kind of family environment that they're coming from. They may be jealous and kind of controlling as adults, and they really have that unwillingness to forgive other people, and they experience that projection of their feelings. So if you remember that little, if you get a chance to see that little extra PowerPoint that I put in for the defense mechanisms, so projection, if you remember, there's a picture of a guy with a heart, and he's got murder in his heart, but actually he is saying they're out to get me, they're out to kill me, but actually he himself has murder in his heart. So they tend to project their feelings onto other people. So if they are feeling murderous towards somebody or hostile, they think that the hostility is actually coming from other people onto them. So they may really feel that, oh, everyone's out to get me. Everyone is, people want to hurt me, they want to kill me, they want to take my money. So they do have that projection of their feelings. Treatment, usually you have to kind of try to counteract that mistrust by just being very consistent, adhering to schedules, kind of making it sure if they're in the hospital, you're going to make sure that they know exactly what time things are happening, and you really kind of have to be very concrete almost in your working with them. Not be overly friendly, because they're going to be suspicious of that. Why in the world would you say something like, I really care about you? You don't know them. They don't know you. They're not going to accept that. And actually, I know it sounds like maybe a nice thing to say to somebody, I care about you. But honestly, that is considered a non-therapeutic technique. So if you look in those 18 pages of therapeutic communication techniques, anyways. It's not therapeutic, because truly that is something that you have to show somebody with your behavior. It is not something that if you say that to somebody, you have to give them a reason to believe that. So that will be by your actions, by being consistent, by meeting their needs. If you say you're going to bring them a snack and a cup of coffee at a certain time, bring them that snack and that cup of coffee. So just being very, just responding that way. But just not being overly friendly is definitely a good thing. So you're courteous and you're polite, but you're more neutral. You're just not going to be overly gushing with them, gushing with positive emotions around them, because that'll just make them more suspicious. So again, that projecting a neutral but kind affect. Psychotherapy versus group therapy. Sometimes if they're paranoid, they may not respond very well to group therapy, so perhaps individual counseling might be just tolerated a little bit better if somebody truly is paranoid. Your book really gives a lot of good information about psychotherapy versus group therapy. They do talk about that it is, it can be very threatening, but on the other hand, it can be a good reality check. If you can get the person there, it can be a good reality check too, because say, for the example in your book is that if somebody is paranoid and they say, I think the group leader is singling me out, perhaps the other members of the group can kind of say, no, give a reality check and say, well, no, the group leader is really trying to get all of us to talk about this issue or whatever. But sometimes it is just definitely hard to get them there. They might need some medication to help, especially if they do have some depression type features and or anxiety. Some anti-anxiety agents can also be kind of helpful for somebody with this. Schizoid personality disorder, so that's nearly 5% of the population, and those characteristics are, again, the symptoms can appear in childhood and adolescence. So sometimes these kids are kind of loners, they don't have any friends, they're not hanging around with people, they may even get teased because of some of their behaviors, or just oddness, or just lack of, engaging with the other kids. They're not doing very well in school. And you have the increased prevalence if you have a really disordered, disruptive type of family life. So they grow up and they really are avoiding close relationships. And they may even have that depersonalization and kind of detachment from other people. So they may feel like they're kind of floating, they're not really real in the world, they don't feel like they're really engaging, in the world, kind of like they're an observer rather than actually participating in life. They can have those difficult types of feelings. What's kind of interesting about that whole aspect of like being detached from other people and not really forming relationships is that they may really have these people might really have difficulty even living with other people. And I really believe that probably a person that was found a few years ago, a homeless person that was found that they had died in one of the area parks. And they didn't find his body apparently for many months because he was homeless. And I would guess probably had this disorder because he really didn't interact with very many people, if anyone. And so nobody missed him for months and months. And then finally his body was discovered. And people then started talking about him and saying things like, if only I had known that he was homeless, he could have lived with me, he could have lived with different family members. There were friends that would have taken him in, except that he just wasn't wanting to do that. He was really not wanting to really have relationships with other people. So I would guess that somebody like that probably had schizoid personality disorder. And it is interesting too because they sometimes just don't seem to care if they have a relationship or not. They're very indifferent to praise or to criticism. So they just don't interact, the same way that most other people do. It's also interesting that both with paranoid and schizoid personality disorder, again, they can both be kind of precursors to schizophrenia, but also that more men than women are affected with this type of diagnosis. So a guide for nurses, again, is to avoid being too nice or too overly friendly because they also will be suspicious about why are you being so friendly to them because they don't see that you would have a reason to be that way. Don't try to increase their socialization. That would be a really, really difficult position to put them in and make them feel very uncomfortable. Of course, you're going to want to try to, on a one-to-one basis, try to interact with them, as much as you can. But you're trying to also assess for symptoms the patient is reluctant to discuss. So really getting at, do they have any interactions with people at all? Do they have any friends, any relationships, any family members that could be a support system to them? But it's difficult because they really don't seem to want to have a relationship with other people. They truly are loners. And if they're in an inpatient unit, we absolutely would want to protect them against ridicule from other patients because they may seem odd and different from everyone else. They may not want to go to groups. They may not be accepted by the rest of the patients. So treatment would be psychotherapy, group therapy, antidepressants. Again, if you can get them to group, it would be very helpful. But many times people with some of these paranoid type personality disorders, eccentric, they don't necessarily seek help, but they may be in the hospital for something else. So they may have bouts of depression or anxiety or psychosis, something else that may bring them, suicidality, something else maybe is going to bring them into the hospital. So, schizotypal personality disorder. So now this one varies from 0.64 to 4.6% of the population. And no, I will not ask you on a test question what percent of the population has this particular disorder. So you don't need to be memorizing things like that, but just try to, again, get the gist of what the personality disorder entails and what kind of a nursing approach are you going to take with this person. So now with schizotypal, they really have very severe social and interpersonal deficits. So again, that inability sometimes to read social cues from people, experience empathy, so they can't put themselves in somebody else's shoes and imagine what that person is going through or feeling. So they have a great deal of difficulties with their relationships, a great deal of anxiety in social situations. So again, group is like, we love group. We think group is a great thing for everybody, but sometimes these people just can't tolerate in any of these three eccentric personality disorders. Sometimes it's just too difficult for them to go to group or to participate. But if you can get them there and just even tell them that they don't have to say anything, maybe they can actually get something out of the group just by being there with other people, even if they remain silent. They might be learning and listening and thinking about things, I guess, a little bit. So they might be rambling in their conversations. So we're kind of almost getting a little closer to being psychotic. So actually having a break from reality. So they may have paranoia, suspiciousness, anxiety, distrust, and possibly brief intermittent episodes of hallucinations or delusions. But the big difference between this and full-blown schizophrenia is that in this type of disorder, personality disorder, the delusions might not be, so a delusion is a false fixed belief not based in reality. It's less entrenched than it would be if somebody had schizophrenia. So in other words, somebody with schizophrenia that has a delusion, you cannot talk them out of it. But you might be able to talk them out of it with a schizotypal personality disorder. And usually the delusions aren't going to be quite as bizarre as they can be when people have schizophrenia. So an example of a bizarre delusion might be the patient that says that he was in a spaceship floating around in outer space for the last 2 weeks. Okay, that's bizarre. That couldn't possibly have happened in reality. But perhaps the person with schizotypal is going to have a delusion that somebody is trying to poison his food. Well, it's not outside, it's probably not happening, but it's not outside the realm of possibility that somebody could be trying to poison his food. So just an example of the kind of the difference between some of their episodes and somebody with schizophrenia. So you might be able to talk them out of it a little bit easier, and you really can't talk out of a delusion if somebody has schizophrenia. So they can be made aware of their own odd beliefs, and so it's possible to give them some feedback and kind of reinforce that that isn't a belief that most people would usually hold. And sometimes these patients may be vulnerable to involvement with cults or unusual religious or occult groups. They may be going to people that are like palm readers, seers. They can see into the future, tarot cards, all that type of thing. They seem to kind of dabble in some of that a little bit too. So just to recap, if you read the article or the paragraph on page 455 in Varkarolis about schizotypal, they really talk about these people are sometimes they come across as strange, unusual, they don't blend in with the crowd, they have odd beliefs, sometimes magical thinking. So let's see, there is an example of magical thinking. So the person who says, "He caught a cold because I wished he would." So something like that, like you think that you caused something to happen. Or if I close the blinds in my bedroom, the sun will stop shining. That would be an example of an odd or a magical belief. So again, we're getting really close to schizophrenia here, and they're even saying in your book that sometimes this is kind of more common in people that have first-degree relatives with schizophrenia. So it's definitely the beginning part of that schizophrenia spectrum, even more so than the other two disorders. So nursing care, again, respect the patient's need to be kind of isolated. So they are not necessarily going to sit down even and have a long conversation with you, and I know as students you love that when patient's going to sit and you're going to have a nice long conversation. They're probably not going to be able to tolerate that. So you may need to have more of a brief, frequent contact kind of approach with them. Meet their needs, be very kind of neutral and not overly friendly, and just, try to help them meet their needs, but it may take a long time to build their trust. So we have to be aware of the patient's suspiciousness and intervene appropriately, which means that we are going to be very out in the open with them. If they want to look at the pill packages because they're not sure you're giving them the right medication, we let them look at the pill package. We don't just say, here's your meds in a cup, and they're all mixed in there and they don't know what's what. So we may have to go very slow with our med pass and show them each package and make sure that they feel comfortable that we're giving them the right thing. They may need, even if they're super paranoid, they may even need only to eat things that are packaged. So something that'll come in a package that they can see it has not been tampered with. So we have to, go along with that. We can't just say, well, here's your tray. It's fine. It came from the cafeteria. They don't poison people. They're not going to believe that. So they may need a package that they can see has not been tampered with, and something that comes, manufactured that way. A bag of chips, a carton of milk, a bottle of water, something that that they don't prepare at the hospital, that just comes on a dish. So that would be intervening appropriately. You might think, well, you're feeding into that paranoia, but actually we're really making them feel more comfortable. And again, we have to watch all of our verbals and nonverbals, the things that we say, how we stand. We don't want to stand with our hands behind our back, because the person might wonder, what have you got behind your back? Do you have a shot for them? Or they just might be really worried about what you're going to do when your hands aren't open. So it's just really being open verbally and non-verbally with that patient. That is the best way to intervene with people that are like this. We have to perform careful diagnostic assessment for symptoms that might need intervention. So in other words, they might be suicidal. So we are going to have to assess them for that. We can't be judgmental with these patients. They are truly suffering. Again, people with mental illnesses do not wish to be mentally ill. They don't cause their illnesses. And so just to withhold that judgment, and certainly as a healthcare professional, we should never be ridiculing patients, especially if they do say something that's really odd or bizarre. We really can't, be ridiculing them for that. So psychotherapy would certainly be a great treatment if they would accept that. And, we might have to see if they are involved with a cult to hopefully encourage them to, to not be. But again, we can't make choices for people. We can encourage people and try to do some teaching. That would be really good. So we have to also monitor if they're on low dose of antipsychotics, kind of monitor their response to that and monitor for side effects. Those would be all appropriate nursing interventions. So now we're looking at the cluster B, which are the erratic personality disorders. So we have histrionic, narcissistic, antisocial, and borderline. So these are all rather interesting. So histrionic personality disorder is about 2% of the population, and they used to call this like hysterical personality disorder. So in other words, then what they say in your book, if you might think about just the word like hysterical and what does histrionic really mean. So they are people that are usually very dramatic, and they can be very high functioning, and they may be, we might use terms like common terms that we might describe somebody as like a drama queen, something like that, or a drama major. So people that tend to be overly dramatic in the way that they express their thoughts and their feelings. They might have some very bold behaviors. They have a limited ability to develop meaningful relationships. They are very attention-seeking, self-centered, and they have a very low tolerance for frustration. So imagine somebody who has this type of disorder maybe coming into the emergency room, and perhaps they want treatment right now. They don't want to be triaged. They feel like what they're there for is very important, and they want to go to the top of the list, even though maybe somebody else just came in with chest pain and they don't have chest pain. They want to be seen first. So that would be a good example of, you know, how they don't tolerate frustration. They're very self-centered. They don't see that perhaps somebody else could be more ill than they are and that they should wait. So so it's very frustrating sometimes for health professionals to work with people with this disorder. They have excessive emotions. They may be very provocative. They really don't have insight into the disorder or their role in ruining relationships. So again, it's kind of externalized, and it's always somebody else's fault. They actually might not even come in for treatment. They may actually be in for treatment of something else. So maybe they're having excessive amounts of anxiety or depression, so they may come into the hospital for treatment of those, or suicidality, but they don't usually come for treatment of this personality disorder, because again, they just really don't have much insight into their own behavior. So treatment is kind of difficult because they don't necessarily come for treatment, but if they did, psychotherapy would certainly be the treatment of choice to try to help them gain insight into their behavior and relationships, especially because many times they just have really difficult relationships. You know, the person feels smothered, overwhelmed by their drama and their constant neediness. So if you can kind of get them into therapy, that would be great. And we just have to understand that as far as us providing nursing care, that sometimes their behavior is a response to their inner distress. And most of the time, when we're thinking about all these disorders, that's really the bottom line. So any of the behaviors that we're seeing that are difficult, it's response to inner distress, and possibly even from their childhood, from stressors and chaotic environments, or child abuse or neglect that they've gone through. So we have to keep our interactions very professional, ignore if they're being flirtatious, use really good language and role model good ways to communicate, help the patient clarify their feelings, teach and role model assertive behavior. Narcissistic personality disorder. So the prevalence, little typo here on this PowerPoint slide, from 0 to 6% of the population usually has this disorder. And some characteristics, and again, you don't need to memorize that, characteristics. So feeling entitled, exaggerated sense of self-importance, and they lack empathy. They don't see other people as having needs or feelings, so they can't put themselves in somebody else's shoes who might be going through something. Whatever they're going through is kind of more important. They tend to exploit other people and maybe use other people. They have very weak self-esteem, and they're very hypersensitive to criticism because they want to be on top. And so that constant need for admiration and all of that, and that lack of empathy for other people, so you can imagine that their relationships probably aren't the best, because it's all about them and less about other people in their lives. So they can be very, very difficult to live with. They do actually, though, however, have less functional impairment than other personality disorders. So they actually can be functioning quite well in the world. So, guidelines again. We need to really kind of remain neutral, avoid power struggles or becoming defensive, and again, role model empathy for other patients or other people. Like say if they're on an inpatient unit and they have this narcissistic personality, they may not be empathetic towards anyone else. And so we as nurses can kind of try to role model that. Not that we're going to be breaching confidentiality or anything like that, but just to try to get that person to see that other people that are on the unit have very important needs and feelings, and that everybody is worthy for the staff to be taken care of, because they may actually get into power struggles about, you're not spending enough time with them, why are you going to that person's room and giving them their medications first, and you're not giving me my medications first. So, we really have to watch that, the way that we respond to that, because it could be very easy to become very defensive. So in role modeling, empathy would probably be a really good thing to do. They may also tend to blame other people too, and not necessarily take responsibility, for their own behavior. So treatment is very difficult, and they may not even seek help. But we have to also kind of understand, though, when people are narcissistic and we think they're really arrogant and they are, it's all about them, they actually have usually a very underlying feeling of abandonment, and they might feel intense shame. So in other words, it's almost like a way to overcome those. So we kind of look at them as somebody who really fears abandonment and fears loss of relationships from other people. It might be a little bit easier to kind of work with them. But cognitive behavioral therapy, certainly we don't necessarily do that as staff nurses, but they would go to an advanced practice nurse or a therapist to try to help them to deal with their faulty ways of thinking, and then to gain empathy with other people and to interact, because they are going to have difficulties with work relationships, school relationships, family and friends, so they're definitely going to suffer that way. So they may, group therapy, again, they may be able to get some benefit from that. Possibly use of lithium, if they are having a lot of mood swings along with that. So there are definitely ways that we need to work with people that have this disorder. Antisocial personality disorder. So about 1.1% of the population has this, and antisocial personality disorder really is very, very difficult, because these are people that are also called sociopaths, and so maybe you're more familiar with that type of term. This is the type of person that is absolutely going to be abusing other people, scamming, getting people into all kinds of difficulties and trying to use them, and they have absolutely no remorse for their behavior. So this is probably one of the most serious personality disorders to have. So they have antagonistic behaviors, they're disinhibited, they have a profound lack of empathy, way more pronounced than the other personality disorders, in that they will use somebody, take all their money, kill someone to benefit themselves, and they have absolutely no remorse whatsoever. So that part of this disorder is really kind of alarming. And so people that end up committing crimes many times have antisocial personality disorder. Or another example might be if you read stories about people that are kind of scam artists, and they get married multiple times, and they're all over somebody and just I love you, and showering them with gifts and making usually a vulnerable woman feel very important and special. Next thing you know, their bank account is cleared out, and they get that woman to maybe sign over their house to them or whatever, and next thing you know, they're gone, and they're on to the next woman, and they get married again or get into a relationship again. They empty that bank account, they just kind of keep going. And again, they actually can commit murder. They actually can kill people for their own benefit, and they have absolutely no remorse. They don't care what happens to that person. So unfortunately, many times these types of personality characteristics are actually evident as a teenager, but the actual diagnosis is reserved for adults. But there is a childhood disorder that we'll talk about when we get to the childhood and teenage learning plan. When we get to that one, we will talk about one of those childhood disorders that's actually kind of a precursor to this antisocial personality disorder in adults, but you don't need to know about that right now. But basically, they just have an absolute disregard and violate the rights of other people. So we do have to realize when we're working with them, when we're making an assessment, if we do see them in the hospital, that they don't necessarily tend to answer questions honestly. They're not used to telling the truth. They're used to lying and twisting things around to get their own needs met. So they aren't necessarily going to be honest. So again, we have to do a self-assessment when we work with somebody like this, because very, very difficult to think how this person has disrupted the lives of other people, perhaps committed crimes, been perpetrators in different types of abuse situations. And actually, as I think about it, we have had patients that have had this disorder on the unit, and it is very difficult to take care of them, especially when you hear about what they have done to other people. So again, we have to put that judgment aside and try to treat them as non-judgmentally as we can, but got to do that self-assessment and see how you feel. If you need any supervision, if you possibly need somebody else to take over for you that can handle themselves in a professional manner. So we really have to kind of watch this carefully, because they really do have very difficult behaviors, again, many times that are actually criminal. They do have some nursing diagnoses that apply here. Risk for other directed violence, more so than self-directed violence, because they're not necessarily going to kill themselves, but literally they will hurt or kill other people sometimes to get their needs met. They just have a basic disregard for human life. They're very defensive. They have very impaired social interactions, ineffective health maintenance. Of course, they're not having, healthy lifestyle when they're, engaged in this type of behavior. So very difficult to treat. We hope that the outcome, at least, is that they will show some self-restraint in their abusive behavior towards others and their aggression. We hope that they can show some self-restraint in their aggression. So these would be some good outcomes that we could hope for. But again, many of these, it's very difficult to accomplish. Many of these patients aren't even going to come into treatment voluntarily. Perhaps they're going to be forced into treatment, or possibly through the legal system, forced into treatment. So we want them to, cope better, have better social interactions, health promotion, health promoting behaviors. But again, very difficult to accomplish. Maintaining safety would be the absolute priority. So we want to try again to work with boundaries, make sure we maintain our own boundaries and not get we don't want to cross the boundaries professionally and start to get into like more of a friendship relationship or social relationship. We have to be very consistent, be supportive, but we have to set limits, offer realistic choices, teamwork and safety. So everybody needs to be behaving and interacting the same way. You don't want to set up for episodes of staff splitting where somebody is giving this person extra privileges and nobody else gets these privileges and other staff aren't, and then you get a really big power struggle going on and you get a lot of anger and agitation from people when staff are not consistent. So we're always going to use therapeutic communication and possibly some medication, some mood stabilizers, if needed. And again, advanced practice would be to hopefully get that person into a therapeutic relationship and do some psychotherapy over time, but they rarely stick to that long-term therapy relationship. Borderline personality disorder. So this one's very interesting. And again, I just don't see a lot of doctors necessarily diagnosing this, only because again, somebody comes into the emergency room with a borderline personality and everyone groans and everyone says, oh no, because their behaviors are so difficult. And one of the things that we see very often is self-destructive behaviors. So they're constantly doing something self-destructive, and then health professionals get very frustrated with that. So that's hence the groaning and the oh no, type of response, especially when they come through an emergency room. So because they may be cutting themselves, they may be overdosing, taking small overdoses, enough to need a treatment, but not enough to kill themselves, and doing all kinds of things that are self-destructive to kind of act out their inner conflict and all of their inner tension and stress. So people with this disorder have severe impairments in their day-to-day functioning. They are very emotionally labile. So their emotions are all over the place. They can be very happy, sad, dramatic, down, just very all over the place as far as their emotions. Very, very impulsive. So impulsive means that there is little time between thought and action. So sometimes they almost bypass the thought and they just go right into the action. A thought comes into their head or an impulse and boom, they do it. They don't sit back and think about it first and think, what would be the consequences of this behavior? So again, those constant self-destructive behaviors, being very antagonistic towards other people, just kind of wanting to do the opposite of what you want them to do. And a very interesting part of this disorder is the splitting. So that is the inability to view both positive and negative aspects of others as part of a whole person. So in other words, they kind of put people into two camps. So when they're admitted on the unit, there are certain nurses that they may have a very positive view of, and they are kind of called, we used to call it like the good mother and the bad mother. So if you were in the good mother camp, that meant that that person saw you as all good. Anything you do would be just fine with them. It's just perfect nursing interventions because you're the good mother. The bad mother can possibly be, for whatever reason, so it might be like a transference reaction. So you kind of remember back when we talked about transference and countertransference. So the patient may have a negative reaction to you based on somebody from their past. It may not have anything to do with what you did as a nurse, but for some reason, you are the bad mother. You are the bad nurse. So no matter what you do, you could be bending over backwards and you could be just as nice as can be, but that person is going to put you, you're already in that camp. You're in the bad mother camp. Nothing you do is right. And they are not going to like you. They're not going to get along with you. They're going to say, I want a different nurse. I can't work with that person. They make me angry. They make me upset. So they don't see that a single person can have both positive and negative characteristics all in that one person. They either put you in, you're in the good camp or you're in the bad camp, and they only see you as all good or all bad. So that has, of course, a lot of consequences then for how they behave on the unit. And again, their ability to work with different staff or not work with different staff. And it also affects the way that they are with other patients and with their own family members and friends. So relationships are extremely difficult for people that have a borderline personality disorder. Along with that splitting, something you might have heard before is called staff splitting. So this is kind of why people staff split. Because staff splitting is like pitting one staff against the other and saying, oh, this person does a really good job when they're here and you don't. So all those types of comments can, staff splitting type of comments and behaviors really stem from that splitting, that inability to view both positive and negative aspects in one individual nurse. So that's kind of why patients end up staff splitting. The prevalence, about 1.6% of the population, and 10% suicide and mortality rate. So 85% of people with borderline personality disorder have another mental illness. So think about what comorbidities you might think go along with this very highly dramatic personality disorder with lots of mood fluctuations and difficulties in relationships. Those are kind of the hallmarks that we're thinking about, that emotional lability, impulsivity, all the problems that they have. So think about depression, anxiety. For sure, suicidality is a very, very important aspect that we have to think about, because they do so many activities of self-harm that sometimes they may not even be necessarily wanting to commit suicide, but they may even just commit suicide kind of by mistake, because they engage sometimes in so many self-harm episodes. So And again, there's just a lot of comorbidities. So 85% have another coexisting disorder. So they could have bipolar disorder too, actually. So high genetic association, they have some separation individuation factors. So again, those might be stemming from very difficult childhoods. They had a hard time with, think about infancy when babies are supposed to be bonding with their parents are supposed to be bonding with their babies. And then the baby, of course, then develops trust. That's really what I meant to say. And so the baby's not developing trust very much. They're going to have some problems with separating and individuating as an individual person as they grow older. So another comorbidity that we can also think about with people that have this, and it kind of goes along with the suicide, the many suicide attempts and self-harm attempts, is substance abuse. So sometimes people have substance abuse issues also as that comorbidity. So we are thinking about different ways to assess somebody. So there are actual structured ways to actually look at and diagnose. But of course, we as nurses aren't doing an actual medical diagnosis of this. We are actually doing our own nursing diagnosis. So, but as far as the medical diagnosis, then certainly a psychologist or psychiatrist would be doing assessments to provide information for this diagnosis. So having a structured interview or semi-structured use of the MMPI, which is Minnesota Multiphasic Personality Inventory. So that would be basically answering a bunch of questions, and out of those questions would come the conclusion that the person has a certain way. Again, a personality is kind of a disorder, is a way of consistently interacting with the environment and people around you. So it would come out from a diagnostic tool like that a person has difficulties with this. So nursing diagnosis that we would have to think about would be self-mutilation, because this happens quite frequently. So it could be cutting, burning, any of the things that people do to self-mutilate and self-harm. Risk for suicide, because they can and do commit suicide, even though they probably have more attempts at self-harm than they do actual suicide attempts. But that is always a risk, because again, sometimes people just take things a little too far and they end up committing suicide when maybe they were just attempting self-harm. So they are very high risk. They are at risk for self and or other directed violence, impaired social interactions, disturbed personal identity. Sometimes they describe themselves as feeling kind of empty or hollow or numb, like they don't even have any emotions. But usually they're very dramatic though when they're telling you about that. So that can be part of it. Almost like not quite as bad perhaps as like that derealization or depersonalization, but sometimes they really don't have a good sense of who they are. Ineffective coping absolutely would be a huge diagnosis for somebody with this type of a personality disorder. So thinking about ways to interact with somebody with a personality disorder, in this chapter 24, on page 463, there's a purple table with a dialogue with a patient with manipulative, aggressive, and impulsive traits. So that would more than likely be somebody with a borderline personality disorder. So there's a really nice conversation. It would just be helpful to read through that, because you'll get a feel for some nice therapeutic communication by the nurse when she's working with somebody who has personality disorder issues. So we always have to think about our outcomes. What are our goals for working with somebody? So we want to really think about the importance of that therapeutic relationship. So it is very important to develop a therapeutic relationship with that patient, but we have to understand that there are times that they may they may put us into the good mother or bad mother category. They may have trouble with forming relationships, or they also tend to do something called, like, they pull you into the relationship. They desperately want a relationship, but then they also push you away. So they have a lot of ambivalence in relationships, but it is very important to try to get a good therapeutic relationship with them and try to avoid those manipulative behaviors and provide clear, consistent boundaries, clear, straightforward communication, calmly review therapeutic goals. And actually, when you're doing that and when you're explaining like boundaries and rules of the unit and things like that, it's just always helpful to make that very neutral and say, this is something we do for all of our patients here on this unit. This is a rule for everyone, and not to really make them feel singled out that this is something that you're just doing for them and no one else. So teamwork and safety, of course, is a huge part of working with somebody with this disorder because, again, the team needs to really be on the same page and everybody needs to be very much aware of what interventions are being used and what approach, and everybody to be very, very consistent. That is very important. And then also to make sure that everyone is doing that very thorough suicide and self-harm assessment too. Responding matter-of-factly to superficial self-injuries is very important. We don't want to give them a lot of attention around their cutting or whatever they're doing, but just to handle it very matter-of-factly. Yes, we have to look at cuts if they do them, but not to give it a whole lot of attention around it. But of course, we want to make sure, of course, that the skin is intact, and if not, perhaps they'll need some Neosporin, a bandage or something to cover it up. We don't want them to get infections, but we don't want to give them a lot of attention or even negative attention, like, why did you do this again? And, cutting doesn't really help anything, whatever we might think is helpful to say, but really is very non-therapeutic. So we certainly don't want to make them feel bad or guilty about doing that either, because if they're self-harming, they are doing it to release tension, and it is their way of handling their inner turmoil and their life's difficulties. So I have a little bit of a story about a person I worked with borderline personality disorder when I was a new graduate nurse. So some of the things on this slide will really kind of come to life as far as clear, consistent boundaries and communication and all that kind of thing. So this patient was in her, she was probably in her maybe 30s, maybe early 40s, and she actually was a nursing instructor and taught mental health nursing in a nearby city. And she came to the unit and she was going to be my primary patient. So that meant I would take care of her every time I was on duty and that I was responsible to develop the care plan. That's how we did things in the old days. But anyways, so she came and she said that she actually came because she said that she was having issues with an eating disorder. So it certainly came out, though, after the doctor interviewed her and really got some information and data, and we kind of observed her behavior a little bit. And clearly, she did not have an eating disorder, but she believed that she had an eating disorder, and that's what she wanted treatment for. So the doctor, I think, in order to gain trust with her, kind of went along with it, and so he ordered, and she was refusing to eat too. She wouldn't have any food because she said she had an eating disorder. And so the doctor ordered milkshakes to be delivered to her 3 times a day. So we had a kitchen on the unit and we had a blender and we could make milkshakes back in those days. So I remember going into the kitchen and when the doctor first wrote the order, and I was putting yogurt and ice cream and peanut butter and all kinds of things, Carnation instant breakfast, all kinds of things into that milkshake. And because the doctor really wanted her to have some calories. So when I first talked to the patient about the milkshakes, that the doctor had ordered the milkshakes, the patient looked at me and she said, "If you bring me that milkshake, I'm going to throw it at you." So I just kind of calmly said, okay. I don't know what I said, but I just kind of calmly, I didn't really like overreact or anything, but I just kind of calmly walked away, went into the kitchen, made the milkshake. But of course, I was a new graduate, and yeah. So, and here, this person was a mental health instructor in another college, so I was a little bit nervous, and I was thinking the whole time, oh shoot, she's going to throw it at me. What am I going to do? And we wore street clothes back in those days, so I was kind of looking at my outfit thinking, well, do I really care if I get milkshake all over this outfit? And Anyways, I was very stressed about going to bring her this milkshake. And I remember she was sitting all alone in the dining room, and I approached her and I just tried really hard to be very matter of fact. And so I just walked in very calmly, and I just set the milkshake down in front of her, and I didn't say a word. I just brought her the milkshake. And what do you think she did? I'll give you a second to think about that. So I wonder how many of you think she threw it at me. I wonder if anybody thinks anything differently. So what she actually did was she drank the milkshake. She did not throw it at me. She drank it. So you might be thinking, why? She said she was going to throw it at you. She drank the milkshake because I followed the doctor's orders. So I was being consistent. I was trustworthy. The doctor ordered it. I told her I was going to bring her a milkshake. I brought her the milkshake. So that was the beginning of her and I developing a good, trusting, therapeutic relationship. If I hadn't brought it to her, I think she was literally trying to scare me off because she knew I was a new grad and, didn't have much experience yet. And I think she was just trying to see if I would actually do what I said I was going to do. So, I passed that test, and then we developed actually a very good therapeutic relationship over time. But again, there were periods of times where things became more difficult with her, such as when she was starting to be discharged. She was there for several months because she really was very unstable, and we did discover that she did not have an eating disorder. She had borderline personality disorder, and that's what was causing her so much difficulty in her life. So once the doctor realized that and we all started working together to treat her for the personality disorder. So she was there for quite a long time. And then, things became we really got much more specific with that versus eating disorder kind of went by the wayside. But as people she got very comfortable with us there. We developed good relationships, good therapeutic relationships. But all of a sudden now it was time to be discharged. And so she really had a difficult time with the thought of leaving the hospital. It was safe, it was comfortable, she trusted all of us. So to leave the hospital and be discharged was very stressful. So when people, even if they're doing better, which she was, once people are being discharged, it can just create a whole slew of negative emotions for them, and they may revert right back to some of their old behaviors. So what she did was she was going for a pass that because she had an apartment, she was actually going to be moving to a new city, and in the same city as the hospital, because that's not where she was from. So she got an apartment, and she was going to be spending part of the afternoon looking at her apartment and kind of getting things settled in her apartment, ready to be discharged and move into this new apartment. So I assessed her before she left, asked her to contract for safety and call the unit if she had any difficulties and all that. And of course she said, yes, I contract for safety and all that stuff. I contract to come back. And so we let her go. And then I was making rounds on the unit, and I just noticed a piece of paper on her desk in her room that I hadn't seen before. And so I went in and just kind of looked at the piece of paper, and it was a suicide note. Dear Mary, I'm very sorry. I don't know what she said exactly, but it was kind of like, I'm very sorry to do this to you, and then she was talking about how she was going to commit suicide. So I was very upset and worried about her, and immediately took that note and brought it to the charge nurse. And, and then the nurse really very calmly understood that action as she's having difficulty separating. So she made me call her, talk to her on the phone, encourage her to come back. And actually, if she hadn't come back, we probably would have called the police to bring her back, but it's a good thing she ended up coming back on her own, because I think having the police involved in her case probably just would have been a little bit difficult. But she did come back. But just having that, all of a sudden it seemed like she was doing so well, looking forward to discharge, and boom, back to impulsive, suicidal type behavior. So that's just really kind of common with somebody with this type of disorder. So pharmacological interventions absolutely can be helpful. They are geared towards symptom relief. So if they have symptoms of depression, anxiety, mood fluctuation, psychosis, any of those, because they actually can have some psychotic symptoms. So basically, they can respond very positively to those particular symptoms, but there is no medication per se that treats any personality disorder. You know what I'm saying? It's not there's no pill specifically to treat a personality disorder, but we can treat some of the difficult symptoms that they have. So the advanced practice nurse would assist staff in maintaining that therapeutic alliance and probably providing some supervision, which is very necessary because they are very difficult to deal with. And psychotherapy, again, would be provided by the advanced practice person. Dialectical behavior therapy, or DBT, is something I'm hearing more and more about, and many of our patients on 1K are being referred to this if they do have a personality disorder, because it is offered now for, I think, the past couple of years in Sheboygan County. So people can go through, it's very long, intensive therapy, but it actually is very helpful. If they stick with it, it is very helpful in helping people with borderline personality disorders. It's kind of very specific treatment therapy approach for people with that type of disorder. Alrighty, the cluster C, or the anxious type of personality disorders. So we have 3 of those: avoidant, dependent, and obsessive compulsive. So all of these have very similar anxiety type components. So people that have avoidant personality disorder, it's about 2.4% of the population. They probably have low self-esteem. They have shyness that actually increases with age. You might think about kids or teenagers that start out kind of shy and they overcome it and they outgrow it as they get older and they get more able to handle social relationships. They actually increase in their shyness as they get older. They feel inferior. They just don't feel like they measure up to other people. They're less than others. They really just don't feel like they're kind of on the same plane as other people. So they have a reluctance to engage with new people because it's threatening. It's very threatening to their self-esteem because they don't feel good. They're not going to measure up with those new people. They are very subject to depression, anxiety, and then anger too. They can be preoccupied with rejection, humiliation, and failure. So, many people you can take a little bit of rejection or a little bit of failure, but, you break up with somebody and you kind of, it's sad, but you bounce back. You don't feel completely devastated by it. But people with this personality disorder would just feel utterly, absolutely worthless and just feel like a complete failure. So they're not able to see the positive aspects of their personality. So another way to kind of think about people with this avoidant personality disorder is that they really do feel very inadequate, very sensitive to rejection. So therefore, they don't necessarily go out of their way to get new, to gain new relationships with people. So they avoid that interpersonal contact because they're really so afraid of rejection or criticism from other people. So you're probably thinking that would really impair them in their life, and absolutely it does. They do end up, that's why it's called avoidance, they do end up avoiding social interactions. They may avoid all kinds of activities, in which case they may feel that they would be negatively judged. Their self-esteem is just really, really impaired. So as far as nursing care, we really need to be accepting. We can be not overly friendly, but of course friendly, open, accepting, and use a reassuring approach. Accept their fears. Their fears are very real to them. It is how they feel. We can't take that away from them and tell them, oh, you shouldn't feel that way. Of course, everyone feels that way. We don't want to say things like that. We just have to accept how they feel. Group therapy can be very helpful for people like this. And different types of exercises that might enhance new social skills. So you'd want them to try to take a risk a little bit, try something new. And they're so afraid of failure, it helps them if they have, a repertoire of skills and that they keep trying different things, because they're not going to be a failure at everything. So it just really does help them to kind of try to broaden their horizons a little bit. So, and then to design exercises to prevent failures And assertiveness. They really aren't very assertive. They may be so avoidant and so kind of shy and not really being able to take risks and things very well. They don't get their needs met. So when you're assertive, you're able to get your needs met and you're able to speak up for yourself. But if you have this avoidant personality, you don't necessarily have the self-esteem to speak up for yourself and to try to get your needs met. So some very important aspects for us to think. Dependent personality disorder. So again, just what it says. People who are very dependent, it's about 0.5% of the population. They have a high need to be taken care of. So they feel dependent on other people. They may be very submissive. They fear separation and abandonment. They may manipulate others to take responsibilities because they don't feel that they can perform those responsibilities. And so they want other people to do them. They're dependent on others, for things that they could be doing themselves or should be doing themselves. And they might have intense anxiety when left alone, even if it's for a very brief time period. So people that have this dependent personality disorder really have a hard time functioning as a fully functional independent adult. Now we all need somebody to lean on. It's not to say that we should be so independent that we don't ever need anybody. So it's very different from that. We all need to have relationships and social relationships and friends and family in our lives. But this is a little bit different from that. So they really have a great deal of difficulty making their own decisions and doing anything without the approval of others. So if you kind of look at the first couple, especially the first couple of bullet points on this slide that need to be taken care of, that being submissive to other people, fear of separation and abandonment, I wonder if anybody is thinking that this personality disorder might be something that people who are abused actually can have. So people that get into domestic abuse types of situations might have, not everyone perhaps, but might have this personality disorder because of the high need to be taken care of and to be dependent on somebody else, and that being submissive and not getting your own needs met, but trying to just make sure other people's needs are met. And that fear of separation and abandonment would make it very difficult for somebody to leave a domestic violence situation. So guidelines for nursing care is to help them address their current stressors. And I think sometimes stressors might become so overwhelming for somebody with a dependent personality that they really get frozen and unable to move forward and to try to deal with their stressors. So we want to set limits that don't make the patient feel punished, because we don't want them to feel badly about themselves. We want to bolster their self-esteem, if anything, because they certainly don't feel good about themselves. We want to be aware of strong countertransference. So in other words, our feelings, so that the transference is what the patient feels, the countertransference is what the staff might feel. So we might feel, really negatively toward this person if we have somebody in our lives that we feel is maybe too dependent and needy and things like that. Some of those negative kind of words that we use when people are dependent on us. So we have to be aware of our own feelings and try to, again, work therapeutically with that person. And we can use that therapeutic relationship with the nurse as a testing ground for assertiveness. So one way to do that that's very helpful is role-playing. So if you help that person with role-playing in a safe therapeutic relationship, that can help them to see their dependent behavior and maybe make some positive changes. And of course, psychotherapy really is the treatment of choice, and if medications are used at all, it would be only possibly for symptoms of anxiety or depression that were debilitating. Obsessive compulsive personality disorder. So this is just a little bit different from OCD, from true OCD, obsessive compulsive disorder. So we talked about that way back in Learning Plan 2. It's an anxiety disorder, but obsessive compulsive personality disorder is just a little bit different. So again, being that it's a personality disorder, it's going to relate, as all the personality disorders do, to a like a typical overtime way of relating to the world around them, to other people, to friends and family. So it's that persistent like pattern that we all develop in our personality. So this disorder is a personality disorder. It is not quite the same as OCD. So we'll talk about what some of the differences are. So it's about 2 to 8% of the population. And the characteristics, there might be a little bit of overlap in some of the characteristics. But people that have the personality disorder are kind of rigid. They have very inflexible standards for themselves and for others. So they really demand the best. They demand that people are, it's usually a demand for kind of perfection. So everything has to be done. It's got to be done the right way. They expect themselves to do it, and they expect other people to do it that way. They do have sometimes a constant rehearsal of social responses. So they might be like constantly going over and rehearsing how they're going to respond in different situations, or if a certain thing is discussed, or if it's discussed a different way, they're going to be rehearsing both ways. So how are they going to respond if it goes this way? How are they going to respond if it goes that way? So they spend a lot of time spinning their wheels, and all kinds of details are kind of floating around. They do have excessive goal seeking that is self-defeating or relationship defeating. So it's like kind of like way past the point of it being productive. So in other words, they actually spend more time perhaps like having all these details lined up. And, they may have a huge list of details to get to a certain goal, but it's actually self-defeating because they spend more time on those details than actually doing the goal, so they sometimes don't even meet their goals. They do have strict standards that interfere with project completion. So it gets to the point where they can be obsessing about details, ruminating, and nothing is ever right, so therefore something doesn't even get completed. So it actually isn't, you might think, well, they're organized, they're, in control of everything, but sometimes they have such control issues and they can't let anything go. Everything has to be just perfect. And if it's not perfect, then they just can't seem to move forward. Therefore, it really stops them from being really productive, because we all have things in our jobs and in our lives that, we want to go well, but if we are obsessing about the details and we can't get past maybe some of the very small details, we'll never get to the big picture and we'll never get anything accomplished. So sometimes things go not even completed because you just can't get through all of these little details. So they just have a very unhealthy focus on perfection. So as you can think, this would probably drive people a little bit crazy that are working with them. So I actually know somebody like this who's on some committees that I've been on in the past, and very, very difficult to work with. Extremely nice person, genuinely nice human being. This person cares about other people, but just sometimes gets so focused on the small details that the big picture gets lost and things don't get accomplished. So, and there are some people that get very frustrated with this person and they won't even work with him on a committee. So they can be just very difficult. So we don't want to get into power struggles because they do have very rigid ways of interacting sometimes, and they really want to be in control of everything. So they have a hard time listening to other points of view. So they really have a hard time. Also, we have to remember that they have a hard time dealing with unexpected changes. So because of their rigidity and they want things to go smoothly and go as anticipated, if something different comes up to throw a wrench in everything, that really throws them off, and they have a great deal of difficulty with that. They might tend to seek some help, and they possibly seek help for anxiety and depression. Group and behavior therapy would be very helpful. They could possibly take some medications that help with the obsessions and the anxiety, and possibly some depression, that goes along with that. So as far as this being a disorder and a style of relating to people is a personality disorder, then I hope that you're understanding the difference between this and true OCD, obsessive compulsive disorder, in that in the personality disorder, they don't have the intrusive thoughts, the obsessive thoughts, and then the behavior which goes along with it, which would be the compulsion. So they don't have a thought of, say, for example, germs, and then the compulsion would be to wash their hands. So they don't have that same type of ritualistic behavior. It's just more being overly detailed, overly, needing control issues and needing things to be just absolutely perfect. So I'm hoping that you're seeing the difference between those two disorders. So I think these are the last two slides here. So we'll be done with Learning Plan 4. So a patient admitted to your unit has a personality disorder. What are some important areas to assess? So overall, if you look at all the personality disorders, maybe not so much for obsessive compulsive personality because they don't tend to be self-destructive, but many of the other personality disorders definitely have a suicidal, self-destructive, self-harm or homicidal aspect. So safety would be the very most important thing that we as nurses really need to assess. And we need to assess how they communicate with other people, if they are paranoid, if they are with reality completely, or if they do have some things that are almost bordering on being psychotic or delusional. If they're trusting or not trusting, and how then we have to really think about how we're going to be interacting with that. But of course, safety is always going to be the number one aspect in terms of safety to themselves and other people around them, and other people on the unit or other people in their lives. So last audience response question: which behavior indicates that a patient diagnosed with borderline personality disorder is improving? So A, the patient cries when her roommate refuses to go to the dining room with her. B, the patient yells at the group facilitator when he points out that she is monopolizing the group. C, the patient informs a staff member that she is having thoughts of harming herself. And D, the patient tells the evening staff that the day staff excused her from group to smoke when she got upset. So I'm hoping that you picked C, because if they're improving, that means that they are able to talk about feelings of self-harm before acting on it. So that would be a huge goal for somebody, and that would definitely indicate that they're improving because they're not going to be as impulsive. So they're going to actually seek out somebody first before engaging in self-harm. So that would be a huge improvement. Not that it's not horrible that the person cries, because it might be an appropriate response if they feel sad, but, maybe they also can, that's kind of a minor thing, having their roommate go to the dining room with them, so perhaps that they still need to work on separating themselves a little bit and dealing with disappointment. Yelling at the group facilitator is not necessarily, positive. They're not able to take feedback because that patient is monopolizing the group and they're not able to take feedback. So that's not really showing a lot of improvement. And then D is a really good example of staff splitting, because the patient is telling the evening staff that the day staff let them have a privilege, and they're trying to get away with something that maybe they shouldn't be getting away with. So that's the end of Learning Plan 4. And if there are any questions about any of these 4 learning plans, please send me an email. And otherwise, I will be sending out a study review sometime within this next week. And good luck!